The second presentation is called Glue to the Rescue. It's on tissue adhesive and bandage contact lenses. It's by Dr. Ikeda Lal. Dr. Lal is unfortunately not able to give the presentation, but she was kind enough to share the talk. And Prajakta, if you can just play the talk from there. The other side. Concept completed. इसके साथ वॉइस है, इसके साथ साउंड है.
हाँ लगी हुई है.
साउंड है इसके साथ.
ऑन करना.
So in that case, I'll just quickly fill in the blanks. So the second talk is about what you had seen, what Prajakta had talked about was, so how do you, what bug do you get, what organism you get, and how simply using Trypan Blue, which is available for all cataract surgeons, can be an aid to find out what is the organism. So what do we do when we have a patient and there is a lot of corneal thinning in the case of infection, and there's a threatening perforation, there's actually a perforation. So the first technique that I think all of us should know how to do is the use of tissue adhesive and bandage contact lens.
Tissue adhesives are used as an emergency procedure to salvage the eye in cases to prevent perforation where we have significant corneal thinning and desmetocele, as a preparatory step right before definitive surgery, like at the time of tectonic keratoplasty, to prevent the prolapse of intraocular contents during trephination, and also as an adjunct to sutures. Now there are two different types of tissue adhesives, the synthetic adhesives and the biological. Amongst the synthetic adhesives, the one that we commonly use is the cyanoacrylate glue. It polymerizes rapidly after contact with a wet surface and has high tensile strength. Whereas fibrin glue is usually used under a biological membrane like the amniotic membrane graft, conjunctiva, or even corneal tissue, and has relatively lower tensile strength. Cyanoacrylate glue may induce vascularization and inflammation. It's relatively inexpensive and does not need reconstitution, and therefore can be used in both OPD and OR setup. Whereas discussing cyanoacrylate glue and its use. The one that we use here is by the name of amicrylate, which is isoamyl 2-cyanoacrylate. This is a monomer which polymerizes. So here when we open the packet, we have the glue in a vial along with a 1 ml syringe and a needle. So we have to load the glue after breaking the vial into the syringe and needle and then use it. How does the glue work? It interferes with interaction between the newly forming epithelium and the stroma. The epithelium forms under the glue, and that's when the glue becomes loose once the surface is epithelialized. It also has some bacteriostatic action, especially against gram-positive bacteria, and inhibits collagenolysis and stromal melting. Indications for which we use cyanoacrylate glue include patients with corneal perforation, desmetocele or significant corneal thinning more than 70%, patients with Murren's ulcer or PUK to prevent perforation, and also as an adjunct to sutures in patients with corneal tear where we are not able to achieve a watertight closure with sutures alone. Now let's see the use of cyanoacrylate glue for patients with corneal perforation. The size should be between 2 to 3 millimeters, and these could be cases of either infective keratitis, neurotrophic like HSV keratitis, or even dry eye related. The prerequisites include a non-epithelialized dry ocular surface, and we should take care that the glue does not penetrate into the anterior chamber. So let's take a look at this case where we did a TABCL along with AC reformation in the OR setting. So here we are using a Merisel sponge to make sure that we have a dry ocular surface, and then we are using the back of the Merisel sponge to achieve a thin layer of glue and to seal the area of perforation without causing a bumpy appearance of the glue. And then we are using a MVR to enter the anterior chamber. Here I would like to share a case of a patient who was referred to us during the pandemic, where there was a paucity of corneal tissues, and we can see that there is a large perforation. She has been on multiple antimicrobial and antifungal agents, and here what we are doing is first using a number 15 blade to take a sample for microbiological analysis, and then we are ensuring that we have a dry ocular surface and then placing a thin layer of the glue. So what we can do here is take the Merisel sponge, dip it in glue, and then press it once more against a sterile surface so that the excess glue comes off and we achieve a thin layer. And then we here notice once we inject a little bit of fluid that there is a leak. So we dry the area of the leak and then apply a little bit more of the cyanoacrylate glue to achieve a watertight closure. And then we are placing an air bubble inside the anterior chamber. Alternatively, a 26 gauge needle can also be used to inject an air bubble in these patients. And then at the end of the procedure, a bandage contact lens has been applied. So this patient was followed up, and this is the first day follow-up picture of the patient. We can see that the tissue adhesive bandage contact lens is in place with an air bubble in the anterior chamber. And after the end of 1 year, we can see that we have a healed corneal scar, and she was taken up for keratoplasty at this point. And this is the first day post-op picture after penetrating keratoplasty. So tissue adhesive bandage contact lens. Now I would like to share these two cases where we have a narrow area of thinning. So the first patient here is a case of neurotrophic keratitis, and we are de-epithelializing the surface before going ahead with application of the cyanoacrylate glue and then drying the surface. And then what we are doing here is using a 26 gauge needle. We have not directly put the glue with the needle but dipped the needle in the glue and then achieved a thin layer of the glue, because this is a narrow area where we need to achieve this kind of a glue effect. So again, in this patient here, when we are using the Merisel sponge in the second case of Murren's ulcer, we were getting a little more glue than we would need. So using a 26 gauge needle, just dipping it in the glue and applying it on the surface works really well in patients like this. Now, post-operatively, we need to put these patients on prophylactic antibiotics and continue the rest of the liquid eye drops. We should avoid gels like the HPMC gel, as they can get stuck on the bandage contact lens, and the bandage contact lens can be changed if needed. The glue should be removed at an average of 4 to 8 weeks, and this duration can be a little longer depending on the size of the perforation, and also in patients with neurotrophic corneas, since the epithelial healing is hampered, we might need to keep this glue for longer duration. Now here I would like to share a case of a patient who has a desmetocele secondary to microbial keratitis and also drug toxicity. So what we did here was that we performed corneal scraping along with cyanoacrylate glue and bandage contact lens application on the slit lamp. And this is after 3 weeks. We can see that the infiltrate has resolved and the scarring is visible under the tissue adhesives. At 6 weeks, the cyanoacrylate glue and bandage contact lens was removed, and we see that the eye has become quiet and the infiltrate has resolved. Over a period of 7 months, her visual acuity slowly improved to 20/100. So cyanoacrylate glue not just helps in preventing perforation, but over a duration of time, these patients might not require definitive surgery. The vision improves, and these can be easily fitted with a RGP contact lens to improve their vision. If we look at the efficacy of cyanoacrylate glue, this study by Setlik et al. Reported that it was effective in treating small corneal perforations less than 3 millimeters, with 40.9% of the eyes healing with the use of adhesive alone without requirement of an additional procedure, and 77. Now, if we look at the complications, the first and foremost is dislodgement of the glue. Second is loss of bandage contact lens, especially if we have an irregular, bumpy appearance of the glue or when we use too much glues. And this tissue adhesive, when bumpy, can cause giant papillary conjunctivitis. Another important aspect to look at is to avoid penetration of the glue into the anterior chamber, as it can lead to toxicity to endothelium as well as the lens. Thank you so much for your kind attention, and once again I would like to thank Dr. Somshila for letting me be a part of this lovely instruction course.